Hello, everyone, and welcome to this webinar. My name is Dr. Tom Madayag. I'm a faculty of the BSN program at Broward College. It is my privilege to welcome all of you to this Nclex series. We're going to meet for 9 times, I think, and I look forward to having a good conversation with you. Just a little bit about myself. I am, as I said, a faculty of the BSN program at Broward College. And I joined them around 2 years ago. Prior to that, I was in the continuing education department at Broward College. And then before that, I was actually doing full-time Nclex tutoring. I go around the world 4 times a year to conduct Nclex courses. At this time, I do Nclex courses twice a week. And majority of my students are actually in Africa. I have 800 students in Africa, in Middle East, in Asia, including India, the Philippines, and China. So this is my passion, and I'm glad that I am able to share my experiences with you in teaching the Nclex. So welcome once again. Now, one of the things that is new as far as the Nclex is concerned is that it now has some case studies included in the examination. And you all know that the items, the minimum items, is still around 85 questions, with 10 of them being experimental questions. But there will be 3 case studies, and each case study will contain 6 questions. And the purpose of these case studies is to see your ability to recognize cues, to analyze cues, to prioritize hypotheses, to generate solutions, to take action, and to evaluate outcomes. That's exactly what we're going to do today and the rest of the presentations of this webinar. And before I forget, please remember that tomorrow our time is a little bit different. The reason for that sudden change is because an appointment suddenly opened up for the global entry. And I have been waiting for this for over a year. So I must appear in that interview. So I appreciate your participation. So again, if you have any questions, please don't be embarrassed, or feel free to go ahead and either chat it in the box or ask, because there's only 11 of you. So that's not going to be a problem in having a conversation with you. Okay? All right. So our first topic for today is going to be on the cardiovascular system. And what I have done in my over 20 years of experience of teaching Nclex is that I have become familiarized with actually the items that oftentimes are going to be appearing in the Nclex. And thus, I had selected the topics that will be discussed in the entire series. Okay? So acute coronary syndrome is where we're going to begin, and that would involve the cardiovascular system. So let's begin. And again, as I said, please don't hesitate to stop me at any time to ask any questions. All right, when we talk about acute coronary syndrome, it refers to a group of conditions that include ST elevation MI, also known as STEMI, as well as non-ST elevation MI and unstable angina. So those are the 3 conditions that describes acute coronary syndrome. This is a condition of coronary heart disease, which is responsible for 1/3 of total deaths of people older than 35 here in the United States. And that is the reason why we begin our discussion today with this number 1 problem, acute coronary syndrome. One cannot talk about acute coronary syndrome without talking about the pathophysiology that usually is going to come out in the Nclex. So let's begin about what causes acute coronary syndrome. The underlying cause of acute coronary syndrome is the formation of an atherosclerosis, or the formation of atherosclerosis known as coronary heart disease. Now, in coronary heart disease, lipids, calcium, fibrate, and other cellular substances are deposited in the lining of the arteries. As you could see in the illustration in the slide, there are now plaques that are formed, and usually these plaques are going to favor those with low velocity blood flow. In other words, the smaller the artery, the more likelihood that coronary artery disease is going to form there. And so it all begins with an injury to the endothelial layer of the artery. The endothelium is the inner layer of an artery. And of course, it precipitates or initiates a series of biochemical events that result in this formation of what we call a plaque. So with the formation of a plaque, it begins with an injury in the inside or the inner lining of the coronary artery. And once there's going to be a growth of this plaque, it narrows the affected vessels, and eventually it disrupts normal blood flow, reducing the blood and oxygen that would be available to the tissues that is supplied by the vessel. So at one time, it was thought that plaque was simply something that grows and grows and grows and larger until it totally disrupts. But that's not actually what happens. What usually occurs is that with the erosion of the cap, there's going to be a thrombus formation, which usually is going to precipitate the occlusion. It's not the continuation of the plaque formation, but rather there's going to be a rupture of that plaque. And that is the one that eventually causes the occlusion of the artery. So that's a brief overview of how atherosclerosis occurs in the heart. And so let's see if you could answer this question for me. And I'm going to have a poll, and I'm going to initiate it now, and you can answer it. Okay, so let's see. Some of you answered letter B, letter C, and some of you said letter D. Okay, so let's take a look at the answer. The answer here is letter D, high levels of LDL in the bloodstream and cigarette smoking. Now, there are two types of lipoproteins, the LDL and the HDL. HDL is the heavenly lipoprotein. I want to call it heavenly. It's actually called high density lipoprotein. But if you think about heavenly as being good lipoprotein, then you will remember that there is a difference between the two types of LDL. HDL does not result in the formation of a plaque. Rather, it eliminates the unneeded cholesterol into the liver for eventual processing. So high levels of LDL in the bloodstream, LDL, low density lipoproteins, are the bad lipoproteins. So these are risk factors for the development of coronary artery disease and therefore acute coronary syndrome. There are other risk factors that we will be talking about, but one of the things that I wanted to introduce to you is that lipoproteins are going to be of two kinds, HDL and LDL. And HDL is the good cholesterol, or lipoprotein, and LDL is the bad lipoprotein because it is the one that deposits in the coronary arteries. Okay, let's go to our second poll. Okay, so let's take a look at this question. The initial precipitating event thought to trigger formation of atherosclerotic plaque in the coronary artery is. Now, one of my specialties is tutoring individuals that failed the Nclex. And this began at Miami-Dade College. And my role at Miami-Dade when I was there several years ago was to teach individuals that are at risk for failing or have failed the Nclex. And one of the things that I have found out is that individuals who failed not necessarily lack understanding of the question, but rather they lack the ability to strategize and to analyze the question correctly. Okay, so whenever you are taking the Nclex, remember that this initial word is going to be a critical word and it's a keyword. So it says that the initial precipitating event, it means that it's the first thing to happen. Okay, so the first thing that happens that triggers the formation of atherosclerosis is not going to be stenosis, which a lot of you answered, but rather it's injury to the endothelial layer. So letter D is the correct response. Okay, are there any questions as far as this question is concerned? Please feel free to dialogue with me, because that's the only way that you can critically think about these things. All right, so the answer is D. The underlying cause of acute coronary syndrome is going to be atherosclerosis, and it begins with an injury to the endothelial layer. All right, let's go to another poll. Okay, so irreversible cardiac tissue death occurs after how many minutes of ischemia? Now, when a thrombus occludes the coronary artery, oxygen supply to that area of the heart supplied by that vessel is going to be reduced. So when the supply becomes insufficient to meet the metabolic demands, the myocardial cells become ischemic, and ischemia can develop within 10 seconds. That's ischemia. Ischemia is lack of oxygen. After 1 minute of inadequate oxygen supply, the heart's function is going to be affected, but irreversible, meaning to say that we cannot do anything about saving that muscle. It's going to occur after 20 minutes. So the correct answer here is letter C, 20 minutes of ischemia. Okay, so let's now go to cardiac risk factors. What are some of the things that increases the risk of an individual to the development of acute coronary syndrome? Well, the common risk factors for the disease are smoking, hypertension, diabetes, hyperlipidemia. It's much more common in males than in women, except for the fact that at the age of 65, women meet the same risk as men do. Other risk factors includes physical inactivity, obesity or overweight, and poor nutritional practices. Now, the reality, particularly here in Florida and in big cities here in the United States, is that cocaine is another leading cause or risk factor for the development of acute coronary syndrome. But the pathology of why individuals who use cocaine develop ACS or acute coronary syndrome is different, because what causes the problem in people who do cocaine is there is going to be vasospasm. The arteries are going to constrict and therefore would precipitate, again, ischemia and eventually cardiac death. Okay, so a family history of early myocardial infarction is also going to be a risk factor. So those are the risk factors in essence as far as ACS or acute coronary syndrome is concerned. So let's go to another poll. Oh, I ended that prematurely. I apologize. So let's see. Can you just type in your answer on the chat box? Okay, so let's take a look at it. You know, evidence have changed as far as the treatment for blood pressure. And this has been revised according to the guidelines for high blood pressure in adults in 2017 by the American College of Cardiology and the American Heart Association. And the guideline recommends that the treatment for hypertension begins with non-pharmacologic interventions. And what are the non-pharmacologic interventions? Well, that would include, for example, losing weight, dietary alterations, as well as exercise. Now, initiation of pharmacologic treatment is going to be different. They recommend that we need to treat patients with blood pressures of 130 millimeters or greater, or a diastolic pressure of an average of 80 millimeters of mercury or greater is the cutoff. And so you all answered 140 over 90, but the new intervention now, or the new recommendation, is letter B, 130 over 80 millimeters of mercury. Okay, and I will add that if we give pharmacologic agents, the recommendation is going to be that we need to start individuals with ACE inhibitors as much as possible. So ACE inhibitors are going to be the first one, except that in the Black population, we always begin interventions with thiazide diuretics. The difference is because there's going to be a different mechanism as far as essential hypertension among Blacks compared to whites. Okay? All right, so please remember that it's no longer 140. We begin interventions when the patient's blood pressure is now higher than 130 millimeters of mercury systolic and a diastolic blood pressure of 80 millimeters of mercury. All right, I want to stop to see if you have any questions or if I'm going too fast, too slow, or too boring. Just please let me know. All right, so is Jacqueline here? I'm just going to take the role. Just type or say yes. Jacqueline, are you here? Jenny, are you here? Okay. And I know Fabiola is here. And Tashawn, are you here? Lauren is here, I know. And Monica, are you here? Yes, you are.
Yes.
And Rachel, are you here? No. Robin is here. Chantal is here. Emmanuel, are you here? Okay. And Lindsay, are you here?
Yes.
Okay, thank you. All right, thanks a lot. Appreciate it. All right, please let me know if you want me to slow down, if you want to ask questions. It's only 11 of you, so we should have a very good time in having an individualized dialogue, okay? So take advantage of that. Now, in my webinars, which I do every Monday and Friday for my international students, I usually have 500 in each class, and therefore it's very hard to entertain their questions. But for you, there's only 11 of you. You should be able to raise your questions and have answers as you please. Okay? All right, so let's take a look at another poll. Okay, so let's see how you all responded. The target level for LDL-C with statin therapy in average risk patients is, okay, so LDL is low density lipoprotein. The answer here is letter A, less than 100 milligrams deciliter for patients with average risk. Now, as far as statin therapy is concerned, this is going to be an important way to manage an increase in lipoprotein. So we're basically going through the normals over here, except for the fact that you're no longer going to have to remember normals because of the fact that Nclex now gives you normals when necessary, okay? But anyway, letter A is our objective over here. LDL, the goal is to be less than 100 milligrams per deciliter. Okay. All right. So let's go to another poll. Okay, so let's review. The answer here is letter B, 18.5 to 24.9. Okay, so this is important because obesity is a well-documented factor for the risk of developing coronary heart disease, and therefore weight management programs and information on eating, as well as having a sensible caloric intake, should be part of your nursing teaching or education. So the goal is to attain a body mass index of 18.5 to 24.9. And to add that, actually a waist circumference of 35 inches in women and 40 inches in men. I'm embarrassed because my waist circumference is more than that. So that is BMI. So remember that the normal, or the goal, I should say, is to attain a body mass index of 18.5 to 24.9. Okay, so if a patient is going to present themselves with symptoms of acute coronary syndrome, what are some of the observations that we will see? Well, the classic symptom of acute coronary syndrome is going to be substernal chest pain. Substernal meaning to say underneath the sternum. And it often is described as, and this description is very important, it is a pressure, a crushing or pressure-like feeling. And this may radiate to the jaw or to the left arm. This classic presentation, however, is not always going to be the presenting complaint. And it could be sometimes in women in particular, patients with diabetes and older age individuals are all going to have vague symptoms. So we do not have the classic symptoms in this population. All right, so I want you to remember that not all individuals with acute coronary syndrome will have this typical pain that is described as a substernal crushing or pressure-like feeling. So whenever there is a high degree of suspicion in these patients, we need to make sure that we think about other manifestations of acute coronary syndrome. And what would they be? Well, they might be not feeling good, nausea and vomiting, for example, not having enough energy. All these things are not classic symptoms of acute coronary syndrome. But in the case of patients who have diabetes, as well as women and elderly, this might be the symptoms that could be presented. Okay, so let's go to another poll. Okay, so some of you actually got confused. All right, the correct answer is letter D, a diffuse pain or pressure in the substernal or epigastric area. Some of you said sharp stabbing pain in the chest. Remember, it's pressure-like pain. Stabbing pain might be associated with pericarditis or with gallbladder disease, for example. But chest pain of acute coronary syndrome is not going to be sharp stabbing pain. It's going to be a pressure-like pain. Okay, so be very careful with those keywords. Okay, let's go to another one. Okay, so the keyword here is atypical, meaning to say that it is not the usual presentation of a patient with acute coronary syndrome. So let me just underline atypical because that is going to be a critical word. So this is not the usual manifestation of acute coronary syndrome. So some of you answered substernal, but that is the typical. Okay, typical means to say that that's the usual presentation. Left-sided, that's also going to be a typical presentation. And pressure type pain is the characteristic of chest pain associated with acute coronary syndrome. The one that's not typical is the one that is between the shoulder blades. So atypical chest pain location includes areas other than the substernal or left-sided area, such as the back or between the shoulder blades, the upper abdomen, or maybe the elbows, the axilla, and so on and so forth. So the correct answer is going to be between the shoulder blades. All right. So let's move on to the discussion of what we do when patients arrive with chest pain. So whenever we have patients that we suspect of having myocardial infarction, we need to think about the fact that these symptoms might be manifestations of not exclusive to myocardial infarction. So whenever we have a patient with chest pain, one of the priorities that we have to do is to determine whether or not this is ST elevation MI or non-ST elevation MI. So how do we diagnose ST elevation MI or non-ST elevation MI? Well, the first thing is we need to do an ECG. Okay. So when we perform an ECG, we're going to identify whether or not there's ST elevation or no ST elevation. So how do we find that? We do a 12-lead electrocardiogram. Now, when we determine that there is going to be ST elevation, then the therapeutic interventions are all going to be different compared to what we would do for patients with non-ST elevation MI and also for unstable angina pectoris. But the ECG is not the only thing that we need to perform in order to diagnose the presence of MI. What we need to do is to do cardiac biomarkers. So in these three populations, when we do cardiac biomarkers, and we're referring to CK or creatinine kinase MB, myocardial band, or troponin, we're looking at whether or not it's normal or abnormal. If it's normal, then that's unstable angina pectoris. If it is positive, that means to say, or if it's high, then that means to say that it's either a non-ST elevation MI and an ST elevation MI. So you might be wondering, what is the difference between ST elevation MI and non-ST elevation MI beyond the ECG? Okay. So when we take a look at the electrocardiogram, obviously in STEMI, the ST is elevated. And in a non-STEMI, the ST might just be normal. There's no ST elevation, but there could be T wave changes. If we take a look at the pathophysiology of this two, when this is the cardiac muscle, so let's say that this is the ventricle, if the damage is going to be from one wall right over here all the way to here, then this results in what is known as STEMI. So STEMI has a more extensive damage. It's from one wall to the other wall. Okay, that's STEMI. In non-STEMI, however, sorry about that. If this is the myocardial tissue in non-STEMI, the destruction of tissue might just be underneath the epicardium, or it might just be underneath the endocardium, or it might be in the middle of the myocardium. So again, let's differentiate. This is non-STEMI. STEMI is when you're going to have a damage from one wall to the other. So which one is going to be more serious? Is it STEMI or non-STEMI? Which is going to be more serious, STEMI or non-STEMI? Yes, STEMI is going to be much more serious because there's going to be more damage of muscles, of cardiac muscles. Okay? All right, so that's the difference between STEMI. Do they both have positive enzymes? And the answer to that is yes. They will both have positive enzymes. What are enzymes? Enzymes are, let's say that you have meat and you bought meat at Publix. You get home and you forgot to put it in the refrigerator. And you only find out the next day that you have not put it in the refrigerator. So what would the color of that meat be? What would the color of the meat be? Hello? Brown or black, right? So whenever they turn brown or black, they're going to release these enzymes because of the death in the tissue. And that's exactly what happens when we measure cardiac enzymes in patients with myocardial infarction. We're actually measuring the enzymes that are released by dead tissue. And therefore, this is going to be a critical test for the diagnosis of myocardial infarction or ACS. Okay, another poll. Okay, so the correct answer here is 10 minutes, letter C. The American Heart Association guidelines maintain that any patient with complaints of ACS, suspicious of ACS, should get an ECG within 10 minutes of arrival. So what's the rationale why that is? Remember, we need to find out whether or not this is STEMI or non-STEMI. The reason is the treatment for STEMI is different from the treatment of non-STEMI. So that is the reason why in 10 minutes after arrival of the patient must have an electrocardiogram. So let's take a look at the algorithm that is provided for us in order to differentiate between the two. Okay, so as you could see, the ECG is an important parameter for us to measure, and we're going to determine if it's ST elevation or ST depression or T wave inversion. ST elevation would be STEMI, and T wave inversion or depression would be non-STEMI. Okay, if there's negative troponin, then that is unstable angina. All right, so that is the reason why we always want to take a look at the electrocardiogram as soon as possible. So whenever you have ST elevations and the ST elevations are going to be significant, then we would call this a STEMI. Here's an example of a STEMI right here. As you could see, the ST is elevated. All right. So you might be asked to identify where the ST is. So remember that this is the P wave, then followed by the QRS. And the link between the S wave and the T wave is what is known as the ST segment. All right. So whenever you are given a diagram, which has been in the past a question by Nclex, what you're going to have to do is to identify where the ST segment is. So it would look like this. All right. So in the electrocardiogram, we always begin with a baseline, and then the small wave is going to be a P wave, and the P wave is a manifestation of atrial contraction. And then you have another waveform, and this is the series of waveform, and this is what is known as the QRS complex. Okay, so this is the QRS complex, and this is a manifestation of ventricular depolarization. And then lastly, a T wave, which is going to be a long waveform, the longest waveform in electrocardiography. And the link between the R wave, QRS, and the T wave is known as the ST. Okay, so you will be asked to have a hotspot to identify where the ST is. Okay, so remember, it is the one after the QRS complex. Okay, so in STEMI, there's going to be ST elevation. In non-STEMI, there's not going to be ST elevation, but rather they might have ST depression and T wave inversion. So that's the difference between the two. All right, so this is a 12-lead ECG, and the reason that I am showing you this is because sometimes they might ask you to identify where the ST is elevated. So I'm now going to show you where the ST is elevated over here. Okay, so in this particular strip, this is the ST right there, and so the ST is elevated. Okay, so this is ST elevation. And the purpose for us to take a 12-lead ECG is to look at different views of the heart. So what's the purpose of a 12-lead ECG? The purpose of a 12-lead ECG is to view the heart in 12 different dimensions, because you cannot see changes just by looking at one dimension. So the purpose of a 12-lead ECG is going to be that we're going to have more views of the heart so that we can see if there's ST elevation in that area. Another Paul. Okay, so the correct answer here is letter A. And so what I'd like for you to remember are the following. So there are some questions that would ask you these particular facts. So ST elevation is going to be a manifestation of MI, right? ST depression is going to be a manifestation of ischemia or a non-STEMI. And Q wave, old infarction. All right, so please take note that an ST elevation is a manifestation STEMI. ST depression is a sign of ischemia or non-STEMI. And Q wave is a sign of an old infarction, the presence of scar tissue. Okay. All right, are there any questions so far? All right. Okay, Chantal. All right, Lauren. Thank you. All right. Great. So let's move on then. So what are some of the laboratory tests that are going to show the presence of myocardial injury? Well, whenever we have a patient that we suspect is having signs of ACS, we always have to do laboratory work to determine whether or not they're positive for cardiac enzymes. So what are some of the important or helpful cardiac enzymes that we might use? Now, there are several. And if you take a look at this graph in letter A, the first actually enzyme that rises immediately after a myocardial infarction is going to be your myoglobin. So myoglobin's levels are only going to be very brief. In other words, in less than 1 hour, it's already gone. So the question in the past, as far as Nclex was concerned, was which of the following is going to be an appropriate test to determine if the patient is having an MI, and the patient just complained of chest pain, okay? So the answer to that is myoglobin, because the immediate reflection of injury is going to be myoglobin levels. But let's say the patient has had symptoms for over 2 hours. Do you still need to, or would you still see changes in the myoglobin? The answer to that is no, because myoglobin levels rises and then disappears in less than 2 hours. So it's not going to be an appropriate test to determine for cardiac damage if the patient has had symptoms for over 2 hours. Now, the most useful of all these is your cardiac troponin. And the reason why cardiac troponin is now the gold standard for the diagnosis of myocardial infarction is if you take a look at letter B, it has the longest, rise. And so if the patient has been having chest pain for 2 days, you still could detect if the patient has had an MI. All right? So I'm going to ask you a question. A patient has had chest pain since yesterday. Would it be better to do a myoglobin level or a cardiac troponin level? Which test would be more appropriate for this patient? Very good, Fabiola. Very good, Tashwani. Because the myoglobin would have been gone. All right. Well, the patient has already had an MI, but he is now in the ICU, and one day after the ICU, he develops chest pain again. Which test would be valuable? A troponin or a myoglobin? Which test would be more valuable? Okay, his second day, yes, we're trying to determine whether or not he extended his myocardial infarction. Okay, good. So the other test that we use is creatinine kinase, or CKMB. CK is an enzyme that is released by any dead tissue. And the unfortunate thing is that when you have skeletal tissue damage, your CK also will rise. And so whenever we're testing for creatinine kinase, CK, there are 3 kinds of CK, okay? MB, BB, and MM. MB is myocardial band. So that means to say that any damage in the myocardium will be reflected in this particular test. CKBB is going to be an enzyme that is going to be abundant in the brain. And MM would be in muscles. So let's say that you have a patient who developed a chest pain after he had an accident, and the wheel, the steering wheel hit him on the chest. Which one do you think will rise? Is it MB, BB, or MM? Which creatinine kinase will rise? MM, yes, the muscle mass, okay? Because he had a muscular injury. Now, let's say that a patient had a car accident and we find out that he had a CBA. That's the reason why he got out of the road. Now, which enzyme is going to rise? Which CK? BB, okay. But if the patient had a rise in MB, that means to say that obviously the damage is going to be in the heart. Okay, good. So you understood that. All right. So this one just shows you what I was talking about earlier, that myoglobin is going to rise, they're going to peak and then eventually disappear. CK 3 hours to 6 hours, and troponin within 4 hours. And over 3 to 5 days. And that's the reason why it is the favored test to determine for cardiac damage. Okay. So let's take a look at another poll. Okay, so the correct answer here is letter C, cardiac troponin, as we had already talked about why that is. All right, so I was ahead one slide. Let's see now about laboratories. What are some of the other tests that we would do in patients suspected of acute coronary syndrome? Well, we also need to have CBC. Why would that be? Because anemia could cause actually myocardial infarction. In anemia, there is a decrease in the oxygen carrying capacity of your blood because of a decrease in your hemoglobin, and therefore could cause myocardial infarction. So CBC is very, very helpful. Basic metabolic panel is also very useful, including a check of blood glucose levels, renal function, and electrolyte for patients with new onset angina. In particular, we're very much interested with magnesium as well as potassium levels, because these are very important in patients with acute coronary syndrome, because low levels of potassium as well as magnesium can cause or predispose them to the development of deadly arrhythmias. Okay? And of course, there's also new biomarkers that we can use. For example, BNP and N-terminal proBNP. These are all elevated in acute MI, and this is a new test. It's an emerging biomarker, so it's not actually going to be widely used. So I want you to just know that these are new tests, just in case it comes out in the examination. Okay? Will we get both as an answer? What do you mean, Chantel?
I think you just answered it. I was talking about the troponin and the BNP.
Okay.
Yeah.
The BNP is much more useful for heart failure, but it's not going to be useful for patients with acute coronary syndrome or MI. So yeah. Okay, good. I'm glad that you're asking questions. Very good. All right. So here is another, we already did this. All right, so what are some of the other tests that we would do in individuals that are going to be suspected of having myocardial infarction? Is an X-ray important? And the answer to that is yes. Chest X-ray is going to be very helpful in assessing the size of the heart. So cardiomegaly, for example, might be present, or even pulmonary edema, which could be a complication of myocardial infarction. So chest X-ray is important. Echocardiography is going to be important because it can assess the overall function of the left ventricle as well as the right ventricle. And then cardiac angiography as well as CT scan are all going to be also important, but they do not have to be done in all patients. So it's selected. And the reason why I'm including all these diagnostics is because in the case studies that you will find out later on, you will always be asked about what other diagnostic measures are going to be done on these patients. So I want you to know that in addition to ECG, there's going to be chest X-ray, echocardiography, imaging, cardiac angiography, and CT scan, and so on might also be done on these patients. Okay, so before we go on a break, because we now have reached the 1 hour mark, we're going to look at the in-hospital care and the algorithm, meaning to say the things that we have to do when we have a patient presenting signs of acute coronary syndrome. All right. So obviously, when a patient complains of pain, you need to assess their vital signs. You also need to make sure that you take their oxygen saturation, because if the oxygen saturation is going to be less than 94, then we might have to start oxygen. It is important that you start IV access, because in the event of an emergency, we need to have an intravenous access to give medications. And again, within 10 minutes of presentation, you must have a 12-lead ECG so that you know whether or not this is semi, non-semi, or ACS, and a brief targeted history, and also a physical examination. Now, in addition to the 10 minutes for ECG, it is important that all caregivers know that a chest X-ray must be performed within 30 minutes of presentation. So these two things, the ECG in 10 minutes, a chest X-ray in 30 minutes, is going to be very, very important. Okay? And lastly, aspirin, 162 to 325 milligrams chewed, not swallowed, chewed in order for rapid absorption to occur. We're lucky here in the United States because when paramedics actually respond to patients presenting with ACS, they immediately give the patient baby aspirin to chew. Right? So that is very, very important. All patients presenting with acute coronary syndrome should receive a non-enteric coated chewable aspirin. Okay, so I wanted to emphasize the non-enteric coated aspirin, right? Because if it is enteric coated, it's going to have a delayed absorption. So it must not be non-enteric coated aspirin. I mean, it must not be enteric coated aspirin. It should be non-enteric coated. Okay? And even if the patient actually is going to have the inability to tell you whether or not they have taken aspirin, we always have to give aspirin regardless, all right? Because it's not going to overdose them at that time. It's going to be very useful to prevent further enlargement of the clot that is obstructing the blood flow. And of course, nitroglycerin. And for narcotic pain, we usually use fentanyl, morphine, or Dilaudid. So I wanted to go over this particular side of the slide to show you what else we need to do in patients who are presenting with acute coronary syndrome. All right, so the primary assessments support ABCs, obtain and evaluate 12-lead ECG, IV access, oxygen, aspirin, nitrate, and morphine if possible, and recommended transfer to emergency PCI capable facility. Okay, so when a patient has ACS and they have STEMI, the intervention has got to include coronary percutaneous transluminal coronary angioplasty, or PTCA, to reopen the artery. And that is why patients are always going to be brought to a facility that has an open cardiac catheterization 24 hours a day. All right, so in the emergency department, check vital signs, start oxygen if necessary, and obtain and evaluate 12-lead ECG, cardiac markers, cardiac troponin, and then, of course, obtain chest X-ray and transthoracic echocardiography. The treatment, oxygen if necessary, chew aspirin, nitroglycerin spray, and morphine if not relieved by nitroglycerin. So, as you could see, if it's ST elevation, then what's going to happen is that you are going to have to treat the patient by reopening the arteries. And there are two ways in which you can reopen the arteries. What are the two ways? You remember what the two ways are for opening the arteries that is clogged? Oops. Okay, so the first one is going to be the administration of thrombolytic agents. And the other one is PTCA, which stands for percutaneous transluminal coronary angioplasty. All right, so that's what's different, because we do not do that for non-STEMI. All right, are there any questions? If not, let's go ahead and take a 5-minute break. So it's now 5:10. Let's go ahead and come back 5:08. So around 5:15. All right, let's have a break. All right, I hope you're all back. So let's continue with our discussion. So what are the priorities whenever patients are presented with signs and symptoms of ACS? Well, you should focus on stabilizing the patient's condition. And of course, the other one is to relieve the pain. And the third one is to provide for antithrombic therapy. And this is to reduce the myocardial damage and prevent further ischemia. So as I said, what are the objectives? The immediate revascularization of the occluded blood vessel. So when you think about it, let me just write something here. If this is the blood vessel and it is now occluded because of the deposition of blood clots over here, one of the priorities that could be done is to dissolve this blood clot. And how do we dissolve this blood clot? Well, fibrinolytic agents or fibrinolytic agents. Examples of that would be your alteplase, also known as TPA. These are agents that are known as clot busters. But the other way that we could do this is to bring the patient to the cardiac cath. And what we're going to do is reopen this, and eventually we're going to insert a spring-like thing like this called a stent. So these are interventions that could be done in order to revascularize or reopen the blood vessel. Okay, so let's have another poll. All right, how about the others? All right, so again, the recommendation recommends that their aspirin should be given as soon as possible after a patient arrives in the emergency department or at contact. And it is going to be a dose of 162 to 325 milligrams, and it should never be enteric coated. It should be non-enteric coated. All right, we do not wait for a diagnosis of acute coronary syndrome. We just give it to them to those without any contraindications. All right, and let's see the next one. Okay, so the correct answer here is to decrease cardiac workload and myocardial oxygen demand. And I think that all of you got this correctly. But I just wanted to digress a little bit to talk a little bit about beta blockers. So beta blockers are drugs that collectively are having a suffix of olol. So whenever you see a drug that ends with olol, like labetalol, atenolol, propranolol, all those are drugs that are beta blockers. So what are the actions of beta blockers? Beta blockers can actually cause a decrease in heart rate. It could decrease cardiac oxygen demand because of the fact that it is a negative inotropic agent, meaning that it is going to decrease the force of cardiac contraction. So negative inotropic effect. All right. So by decreasing the force of cardiac contraction, you're making the heart rest. So it decreases the demand for cardiac oxygen. It has been found out to actually be very useful for patients who have a myocardial infarction because it decreases mortality. So what are the side effects of beta blockers? Well, the side effects of beta blockers and contraindications include the following, all right? So they will have a decrease in their energy levels. There will be a decrease in heart rate, and there will also be a decrease in blood pressure. And the most important thing, it always comes out in Nclex, is that it decreases glucose production. So when a patient is going to be diabetic and they're taking anti-diabetic drugs, they're going to mask the signs and symptoms of hypoglycemia. So this is a common prevailing question in the Nclex as far as beta blockers are concerned. Now, beta blockers are of two kinds, beta 1 blockers or beta 2 blockers. And to remember that, we have one heart and we have two lungs, okay? So when you block beta 1 receptors in the heart, it decreases heart rate, it decreases the force of contraction. Beta 2 is going to, if you block it, you're going to cause bronchoconstriction. So it would be therefore contraindicated in patients who have respiratory disease because of bronchoconstriction. That is the reason why when we give beta blockers to patients with respiratory problems, we only have to block beta 1. And these are called beta or cardioselective beta blockers. So cardioselective beta blockers. These are going to be the ones that you would give to patients with pulmonary disease. Okay? All right, so that's all about beta blockers. All right, so what is the pharmacologic treatment for patients who have STEMI? Well, for analgesics and sedation, morphine is the favored drug because it can relieve chest pain. It can also alleviate the work of breathing, reduce anxiety, and actually would decrease the ventricular load and therefore decreases the work of the heart. And that is why morphine is a favored drug, because it could be given in small doses. Now, nitrates is also going to be very important in the management of patients with acute coronary syndrome and myocardial infarction, because it could provide symptomatic relief by means of several mechanisms, including vasodilation. And therefore, it is going to be very useful. But I want you to also remember the following, that when you give nitrates, what's going to happen is that it will decrease blood pressure. Why would it decrease blood pressure? Well, because it dilates both the arteries and the veins, and therefore this decreases preload. Preload is the amount of blood that goes back into the heart. So when you decrease the amount of blood that goes back into the heart, you're going to decrease blood pressure. Okay, so always remember that hypotension can occur with the administration of nitrates. So you should not administer nitrates if the systolic blood pressure of the patient is going to be less than 90 millimeters of mercury. Okay, so how about oxygen? Do we give oxygen to all patients? The reason why I have a question mark over there is because it is controversial to start oxygen right away. And the reason for that is oxygen has a vasoconstrictive effect. So routine administration of aspirin is not recommended whenever the patient's SaO2 is greater than 90%. If it is less than 90%, then maybe oxygen is going to be very useful, and we usually would give a low dose oxygen. All right, so remember that oxygen can cause vasoconstriction and therefore can worsen the situation and decrease blood flow. So give oxygen only when it's clinically relevant, such as if the O2 saturation is going to be less than 90%. Okay, let's have another poll.
Claudia?
I'm trying to mute everyone, but okay. Okay, so a lot of you answered aspirin. Why do we give aspirin to these patients? We all know that aspirin has many actions. Among them is going to be it's an analgesic, antipyretic, anti-inflammatory. But it's also going to be a drug that is going to affect platelet aggregation. So aspirin is not given to relieve pain, but rather to decrease the further formation of blood clots. So letter A is incorrect to manage pain associated with myocardial infarction. Ticlopidin is the same thing. It decreases the formation of blood clots. A non-steroidal anti-inflammatory drug is going to be not appropriate for the management of patients with myocardial infarction because mainly this one has anti-inflammatory effects and therefore it's not considered to be a drug of choice in the management of pain associated with myocardial infarction. Letter D is the correct response, all right? And unfortunately, a lot of you answered aspirin, ticlopidin, and NSAID. Again, I told you that the drug of choice is either going to be morphine or nitroglycerin. Okay, nitroglycerin or morphine. Okay, so once again, we said that anytime that the SpO2 is going to be less than 90%, then we're going to start oxygen. So the correct answer is letter D. Okay, all right. So let's go to pharmacologic interventions. Now, the antiplatelets that are going to be very useful for the management of patients with myocardial infarction include your aspirin, your clopidogrel, ticagrelor, ticlopidine, dipyridamol, and so on. So this is going to be the drugs that are going to prevent further coagulation and therefore prevent another occlusion of the blood vessels. So these are some of the examples of your antiplatelets. ACE inhibitors are also going to be useful. And ACE inhibitors are those that end with pril. An example of that would be lisinopril, captopril. So anytime you hear pril, you're going to always think about ACE inhibitors. And ACE inhibitors are going to be very useful after myocardial infarction because, like beta blockers, they reduce the mortality of these patients. And the other drugs that could be given are angiotensin receptor blockers. These are the ones that end with the sartan. Examples of that would be losartan, candesartan, valsartan. Anytime you hear sartan as the suffix of a drug, this is going to be an angiotensin receptor blocker. So what are the actions of ACE inhibitors and angiotensin receptor blockers? Again, with ACE inhibitors, they can decrease blood pressure. And this is going to be the primary reason why it is often used in patients with hypertension. And then, of course, beta blockers, as I said, and they are the ones that ends with the suffix olo. And because the atherosclerosis is the primary reason why there would be obstruction, then statins are going to be used. So any drug that ends with statin, like lovastatin, are going to be drugs that are going to be initiated in patients with acute coronary syndrome or MI in order to prevent further occlusion of the blood vessels. Okay, so one of the ways in which you could remember the medications or in the interventions that are going to be useful in the management of patients with myocardial infarction is to think of Monarch Basic. And Monarch Basic will clue you to the following: morphine oxygen nitrates, aspirin reperfusion, and it could either be through thrombolytics or percutaneous coronary intervention or PTCA, clopidogrel, and heparin. And then the basic would be beta blockers, anticoagulants, statins, inhibitors of angiotensin II or ARBs, and correction of risk factors. So those are the important interventions for these patients whom you suspect to have myocardial infarction. Okay, enoxaparin is going to be a heparin-like medication that is given to patients in order to prevent further blood clot formation. Enoxaparin is given only subcutaneously. Okay, so this is a high alert medication and it is going to be very frequent in the Nclex. So enoxaparin is given subcutaneously, usually in the abdomen. And this is going to be given for the purpose of anticoagulation. Okay, please remember this drug, enoxaparin. All right, the parin should clue you to the fact that it's like a heparin. It's a low molecular weight heparin medication. All right, so one of the interventions that I have described is bringing the patient to the cardiac cath lab and to do reperfusion. And so reperfusion could be done either to the administration of drugs or thrombolytic agents, and would be the preferred one would be PCI or percutaneous coronary intervention. And that is when we go to the cardiac cath and go to the area where there is an obstruction, see over here. And once we go over there and dilate it, and we move the blood clot and the obstruction, as you could see, there's going to be reperfusion again. And that's exactly what reperfusion does. It now is going to open up this blocked artery. So that's percutaneous coronary intervention. That's what PCI means. All right, so the correct answer here is letter C, 90 minutes. So in order for it to be effective, it has to be done within 90 minutes from the time of patient's arrival in the emergency room. Okay, so don't be confused that the 10 minutes, the 10 minutes is for the ECG, remember? And the 30 minutes is for the chest x-ray. So within 10 minutes of arrival, the patient should have an ECG. Within 30 minutes, the patient should have a chest X-ray. Within 90 minutes, you should have PCI, or percutaneous coronary intervention. All right? PCI is when we reopen the artery in the cardiac cath lab. Okay, so the correct answer here is letter D, a prior intracranial hemorrhage. All right, so what I want to do in this slide is to tell you that there's a difference between anticoagulation, anticoagulant, and antithrombic. Or a fibrinolytic. Fibrinolytic. Okay, so anticoagulants like heparin and coumadin prevents blood clots. Fibrinolytic agents dissolve blood clots. So if you already have a blood clot, do you give an anticoagulant? The answer to that is, well, if your purpose is to prevent further, blood clots, yes, but you are not going to dissolve that blood clot. You can only dissolve a blood clot with the use of a fibrinolytic agent, okay? And examples of that would be streptokinase, anything with an ACE, alteplase, TPA. Right. So it stands to reason that when a patient undergoes fibrinolytic therapy, that they should not have any prior intracranial hemorrhage or active bleeding for that matter. Okay? All right, so here are the contraindications for fibrinolytic agents. Any prior intracranial hemorrhage, if they have a malignant intracranial neoplasm, or maybe ischemic stroke within 3 months. These are going to be contraindications for the use of these agents. So they're much better to go for a PCI rather than to receive alteplase or TPA. Okay, so active bleeding, significant closed head or facial trauma, intracranial or intraspinal surgery, and severe uncontrolled hypertension are going to be contraindications for the use of fibrinolytic agents. But what I want you to remember is that you don't want anything that predisposes the individual to more bleeding. In particular, if the bleeding is in the head, because it will cause a lot of damage when you do. Okay? All right, Chantal, you have a question? Go ahead.
I think you kind of answered it.
Oh, okay.
I wanted to ask you what, like when I'm trying to like figure out what the question is asking and the word that says absolute. So in my mind, I'm thinking like the odd one out. I'm wondering if that's the right way for me to think of the question when I see it.
Yeah.
I did get the answer, but
yeah,
for the word absolute in the sentence.
Uh-huh. Like, for example, in this one, it's an absolute contraindication, which means to say that in some instances, you can gamble. For example, you're going to weigh the risk versus the benefit. But when
Yeah.
you say absolute, anytime a patient is bleeding of any time, that means to say that's an absolute contraindication. So 100% that you cannot give this medication.
Oh, okay.
Yeah,
Got
it's
it.
100%.
Got
Very
it.
good. I'm glad that you're engaging. Wonderful. I love questions. Okay. So let's go to this question over here before we go to the other thing. Okay, so immediately following reperfusion with fibrinolytics, the patient is at risk, obviously, to develop bleeding, right? So you're going to watch for bleeding. But in addition to that, we must have continuous ECG monitoring, frequent vital signs, and very, very important, actually, is neurological checks. And the reason why we want to have neurological checks is because of the fact that intracranial bleeding is a complication that might occur, and they have very slow signs that might be presented. And that is the reason why you want to make sure that you do neurological checks very frequently. So let's see now if we could answer these questions on the, not this one, the case study. And so our case study is this. You have a 60-year-old male admitted to the emergency room with crushing sternal pain, radiating down the left arm that is worse with walking. Pain began 2 hours ago while walking outside. The client also reports shortness of breath with activity, reports taking a regular aspirin on the way to the hospital. The vitals are 99, 110, 22, 160 over 90, 93%, chest pain 8 over 10. And the weight is reported at 280 pounds, a BMI of 35. Okay. Started on unit chest pain protocol, oxygen is applied, and nitroglycerin is given. A peripheral IV has been in place in the client's left arm. Morphine was given, and labs were drawn. And the ECG shows sinus tachycardia with a rate of 110, an ST segment elevation in V3 and V4, also known as the anterior leads. And the laboratory report shows you the following. And so now the question is, and this is exactly how the case study questions will come. Which two findings are most significant? All right, could you please put in the chat box what your answers are? Choose A, B, C, D, E, or F. You need to choose two. Chantel, one more answer. It's asking you for two. Okay, so let's analyze what the correct answer should be, right? So the ECG shows ST segment elevation. Is that something that is going to be significant? And the answer to that is yes. So letter A should be one of those. Remember, ST segment elevation, what does that mean? The patient has STEMI. All right. And the other thing, if we look at troponin T, the result is 0.5, and normal should be 0.04. So this is elevated, which means to say that we're going to have signs and symptoms of myocardial infarction. So troponin T would be the appropriate response. So letter A and letter E. So let me see why some of you said CK is going to be important. But if you look at the CK, it is going to be, what do you call that, elevated. But what did I tell you? CK is going to be not the gold mark for diagnosing myocardial injury. The gold standard is going to be troponin. All right. So do you understand why letter E is not going to be the correct response? All right. Okay, so let's go further. For each client finding, click to specify whether the finding is consistent with ST elevation MI, non-ST elevation MI, or unstable angina. Each column must have at least one option selected. So let's begin with CK, creatinine kinase. Is this something that would be present in STEMI, non-STEMI, unstable angina? So could you please put S, N, or U if you select all of them, or S for STEMI, N for non-STEMI, or unstable angina, just for the creatinine kinase. All right, let me ask you, is creatinine kinase going to be a diagnostic marker for MI, yes or no? Should we check this, yes or no? Put in the chat box. All right, so Lindsay said yes. How about the others? Chantal did the same thing, good. All right, so yes, creatinine kinase would be reflected in the in STEMI, it would be present. How about in non-STEMI? Okay, yes or no? Non-STEMI, yes or no? Would you have an increase in creatinine kinase for patients with non-STEMI? Yes. You remember in both STEMI and non-STEMI, there is damage to the myocardium. In unstable angina, there's no damage. So we should not check unstable angina. Okay? How about crushing chest pain? Can you have crushing chest pain with STEMI? Yes or no? Would you have crushing chest pain with STEMI? Yes. Okay, very good. Would we have crushing chest pain in non-STEMI? Yes. Okay. Can we have crushing chest pain in unstable angina? Yes. Okay, good. So we would check all three of them. All right. How about ECG changes? Do you have ECG changes in STEMI? Yes. Very good. And the ECG change would be ST elevation, wouldn't it? Now, you would not have ST elevation in non-STEMI as well as unstable angina. All right. Elevated cholesterol. Will you have elevated cholesterol in STEMI? Yes. You would also have them in non-STEMI, and you could also have them in unstable angina. Because you remember, the pathology is going to be the same. All right. Obesity is the same thing, right? Can you be obese as a risk factor for the development of STEMI? And the answer to that is yes, also with non-STEMI and also with unstable angina. But what I'd like to ask you now is troponin T. In STEMI, would you have troponin T positive? Yes or no? Yes, okay. And how about for non-STEMI? Remember, both of them has damage. Yes, yes. Both of these, STEMI and non-STEMI, have damage. So they should have a positive troponin. The difference is that in STEMI, the ECG shows ST elevation, and in non-STEMI, the ECG does not show ST elevation. I'm sorry about that. Okay, so do you see where you got it wrong? And that's okay. That's why we're here. All right. So let's go further. For each client finding, click to specify. Oh, we already did this. I did this. Okay. The next question is, the nurse should recognize that the client is most likely experiencing what? ST elevation MI, non-ST elevation MI, or unstable angina? Your answers? Okay, I saw the answer for Lindsay. How about the others? Very good. The answer is letter B. This patient is suffering from ST elevation MI. You remember that ECG that showed ST elevation? So the patient is positive for STEMI. Okay. So complete the following sentence by selecting from the list. The nurse should recognize that the client is most likely experiencing STEMI caused by coronary artery what? Blockage, rupture, or spasm? Your answers? Okay. So you remember at the beginning, I said that the event for the formation of atherosclerosis is this. There's going to be formation of lipids and calcium deposits in the intimal lining of the artery. And then what happens is that there's going to be a rupture of this particular areas right here. And therefore, what's going to happen is bleeding is going to occur. And so the first is going to be intimal damage. The second event is going to be rupture of this formation over here. And the third is going to be occlusion. Okay? All right, that's okay. All right, so the client receives a diagnosis of ST elevation MI. For each potential medication order, click to specify whether the medication is indicated or not indicated to include in the plan of care. So, which ones are indicated? All right, so select all that apply. All right. Okay, very good. All right, so let's take a look at it. Do we need analgesics? Obviously, when a patient has an MI, we would need to give them either morphine or nitroglycerin or both. All right. How about antibiotics? Antibiotics are not needed. How about anticoagulants? Yes, we do need anticoagulants. So you remember us talking about the administration of low molecular weight heparin like enoxaparin. All right. How about beta blockers? Yes, beta blockers are going to decrease mortality, so that's going to be okay. We don't need any fluid bolus. You only give fluid bolus if there is going to be hypovolemia. But the patient with myocardial infarction does not necessarily have hypovolemia. And fibrinolytics, yes, these are going to be important. So the correct answers here are A, C, D, and F. All right, so the patient now has these orders of medications. All right, so the orders are enoxaparin, metoprolol, tenecteplase, morphine sulfate 2 milligrams IV every 15 minutes as needed for pain. All right, so did you see the orders?
Yes.
Okay, good. So from the orders, the nurse should give what next? All right, so let's take a look at the first one first. The nurse should give this one first. Which one? A, B, or C? Could you please type your answer? Which one would you give first? Okay, so enoxaparin is going to be an anticoagulant. Metoprolol is going to be your beta blocker, right? Enoxaparin is anticoagulant. Metoprolol is a beta blocker. And tenecteplase, ACE, is going to be a fibrinolytic. Of all these drugs, which should be given first? Okay, letter C. Very good. All right. So, which should be given what? Immediately, within 30 minutes, or within 90 minutes of admission? You remember the 10, 30, and 90 minutes? Okay, within 90 minutes. So the correct answer is letter F. Very good. Okay, so now these are now the vital signs at 10 o'clock. At 10:30, I'm sorry. Okay, so the yellow highlight is the original vital signs, and at 10:30, the vital signs are now 99 degrees Fahrenheit, which is the same. The heart rate is 120, which is more than 110 from the original. The respirations is 22, which is the same. The blood pressure has now come down to 150 over 85. And the pulse oximeter is 95, which is higher than 93% because the patient is on 2 liters of nasal cannula, and now the pain is 6 over 10. Remember, it was 8 over 10 before, and now it is 6 over 10. Okay? All right. So, with that in mind, the nurse reassesses the client after initiating the chest pain protocol and giving place. For each finding, click to specify if the finding indicates the client's status is improved, declined, or is unchanged. All right, so let's go to the pulse. Is the pulse much better? The pulse was 110, and now the pulse over here is 120. That has not improved. Okay, very good. How about the blood pressure? The blood pressure was 160/90, and the blood pressure over here is 150/8. Okay, very good. Yes, the blood pressure has improved. How about the pulse oximeter? It was 93, and now it is 95, and on 2 liters per minute. Yes? Okay. How about the respiratory rate? The respiratory rate was 22, and now it is 22. So that has not changed. Okay. And how about the pain? The pain was 8/10, and now it's 6/10. Yes, it has improved. Very good. So now you're getting an idea. And so that is the end of the presentation, but don't leave, because I'm going to give you the link of the exercise, the case study, so that you can answer it yourself, okay? Hold on one moment, Gmail. It's not possible for you to do it together, because it is going to lock you out. So I'm going to give you the case study. I want you to go there and then see what you have missed, okay? All right, so I'm now going to put it in the chat box. This is the link, and you don't have to do it now. You can do it anytime, all right? Just copy the link, and that concludes our presentation for today. So I want to know from you if we have to do something different. So I'm going to send you an evaluation form just to let me know how the class is going, because this is our first day, and I want to make sure that I address what you need, okay? So tomorrow, what we're going to have is respiratory, and we're going to talk about heart failure. Not respiratory, cardiac still, but heart failure is our topic, okay? So Lindsay, Chantel, Fabiola, and Monica, thank you so much for your participation, and I'm going to email you the evaluation that you need to do. Thank you so much, okay? Have a great evening, and remember, tomorrow we have a different time, all right? So I just want to make sure that you're aware of that.
Thank you.
Yes. You're welcome, Chantal. Have a good evening.
You too.
Fabiola, good night. And Monica and Lindsay. All right, thank you. Bye-bye.
Thank you.
You're welcome.